Hi everyone, this is a presentation for Advanced CPT and HCPCS Level 1 and Level 2 coding, and it's by me, Roseanne McGinn, your guest instructor this quarter. So where I left off was professional versus technical component. The professional component covers supervision of the procedure and the interpretation and the documentation of the report. So it describes the examination and it describes its findings. And the technical component covers the use of the equipment. So that is the supplies that are used, any sort of physical equipment, employees, hourly costs, anything like that. So if the clinic or the private office owns the equipment and has hired their own professionals to use that equipment for services, and they're performed with all of that equipment, then both the professional and the technical components are billed on the same claim. If not, they're billed separately. This applies to all different levels of CPT coding, but specifically to radiology. So always be careful with modifier number 26. I want to point this one out because it's important. There are two separate billings that are required. A HCPCS Level 2 modifier is used for the technical component, or as the modifier is written, TC. And the professional component is billed by adding modifier 26. So when you have to split those two apart, which happens a lot of little providers will send you to have your ultrasound done somewhere, or your x-ray done somewhere, or whatever. So then you only bill for the professional component and you add modifier 26. If you have the equipment at that facility, you do not ever add modifier 26, and that's the biggest mistake I see for radiology, and actually for all services this type of rule is applied. So kind of think about that. So then there's a pathology and laboratory section in CPT. It's organized by the type of pathology or lab procedure performed within the subsections. The procedures are alphabetized, with the most common disease panels being for genetic diseases, actual tissue illness. That's what most of these come from. There are several different categories that are subcategories of that. And then drug assays, so there are different ones. There's ones like for pre-employment. A lot of people have to go have a urine test done to see if they pass a drug test. And with a drug assay, there's also treatment-based drug assays, which are to track drugs, the propensity of them of being in the system of the body. If they are potentiators, they really want to monitor those. So they'll track that usually via blood and not urine, but sometimes urine. So that's one that can be billed also. And so I have a little picture. It says supercoder.com, illustrated pathology and laboratory. If you get into just pathology and laboratory coding and that's where you end up, you'll probably want to get a book like this or this exact book. I like this book. It has pictures, it's color coded, all the cool stuff. You can look at that stuff on the website I provided on the PowerPoint. So there's also a medicine section. There's non-invasive procedures. They require no surgical incision or excision, and they do not include open procedures. So if it says it's an open procedure, it can't be non-invasive. And then there's minimally invasive procedures. So that would be like a percutaneous access via a needle or a very small cut. And then invasive procedures are you're going into the body full on. And that's pretty much all other surgical types that don't fall into the first two categories. Subsections of medicine. There are different subsections of medicine, and they classify procedures, and procedures are oriented via the types of services. For example, immunizations. They apply to various medical specialties such as gastroenterology, chiropractic, any of that kind of stuff. Apply to different types of healthcare providers, including physical therapists, nurse practitioners, skilled nursing facility workers often fall into this category, like rehabilitation services, anything like that. So all of these, for coding purposes, fall under the National Code Correct Initiative, so NCCI. NCCI is actually associated through Centers of Medicaid and Medicare Services, so CMS, and HHS, Human Health Services. So they definitely have a lot of different red flags that they'll send up if they see you doing anything that is listed in this book. So it's good to acquire this book. They update it every 6 months, and I would say most offices need to have this book. If you are in charge, you tell them they have to have this book. If you are the only coder, you tell them you have to have this book. A lot of times there's a lot of expense for coding and doctors don't get it, especially in small practice. So if you are coding for small practice, you might have to buy these books and then write them off on your taxes. But it's worth it to have the new updated book, especially if you're finding you're having a lot of rejections. If it doesn't happen very often and you're able to figure out why it happened when it happens, you don't need to buy this book. There are over 140,000 code pairs. So it says these two codes cannot be coded together, or these two codes have to be coded together. So they track both of those. And they cannot be coded together on the same date or bill claim for the same person. CCI edits are pairs of CPT and HCPCS codes that are not separately payable except under certain circumstances. So they send up a big red flag like, what's going on? For example, to record the correct modifier. So if for some reason you put a HCPCS code and you leave off the CPT modifier that it requires, that could send up a red flag. All these results in a red flag. A red flag means the claim is denied or not paid. So, medically unlikely edits, MUSE. You never hear people call it a medically unlikely edit. They call it MUSE, and that's probably just to confuse everyone. Medically unlikely edits automatically result in a rejection of the claimant for the services, are used by Medicaid and Medicare claims. Other insurance providers actually use them or their own version of them. They determine if the claim will be automatically paid or rejected. And the hardest part of coding, because you have to stay up on it, it's a lot of reading. Coding's a lot of reading. It's a lot of reading. Just keep reading. You need many, many books, and you have to be able to read them to really get the full payment. And so that's why in big hospitals, they have people who are so highly specialized. Like they only do HCPCS level 2 codes, and they only do CPT codes with HCPCS level 2 modifiers. And then these people over here only do ICD-9 CM coding, and these people over here only do ICD-10 PCS. It's very rare that a coder is proficient in all of these types of coding. That's why there are certs that apply to specific types. But I think it's worth learning all of them, because then you can pretty much have your pick of what kind of job you want to do. All right, so there are different types of rejections. Return to the provider is the type of rejection. It means that something the provider said in the record led to an incorrect code, or that the provider just needs to review it to make sure that the code selection is correct. Now, notice I said the doctor. Coders are in charge of really doing that part, but I have to say that technically the legality of it falls upon the doctor or the medical group that is doing that, the billing. So sometimes it goes back to the provider just for a glance to make sure, whatever. Maybe there was a problem with the way they put in the record something and it was unclear to the coder, so the coder didn't pick the best code. And so it might have been on one of these medically unlikely edits. Maybe they made an error in addition to that. For example, let's say that there's going to be a surgery on the inner ear, and we are putting a device and we're doing it on the right side. Well, I could put the CPT code for this procedure, and then I could put right side RT modifier HCPCS level 2. And then I could put a modifier on there ×3. Guess what? I didn't do that procedure to anyone ×3 on the same ear. That's not possible. So that is a medically unlikely edit. And it gets canned. It's like, no, this is not possible. This is not okay. Go back to your doctor and have them explain what you did wrong, or go back to your coder and the coding manager to see what went wrong, and then edit it and you resubmit, as long as it's within the timeline. So then there's a line item rejection. So it could be like, we're covering and paying all of this stuff on the bill, except you billed for crutches. And you shouldn't have billed for crutches because you are not registered with Medicaid and Medicare as a durable medical equipment provider. You should have wrote a prescription and they should have went and picked that up, or you need to become a durable medical equipment provider. Okay? So just that one little part of the bill is thrown out. And then suspend. That usually means that it's a service that Medicaid and Medicare are in the process of getting rid of coverage for via law. Usually there are actually specific procedures that by law are just not covered. So you can go to www.cms.gov. They show the NCCI edits available for purchase at ntis.gov. And you can have your work purchase them if they have a high rate of rejection especially, or a large office for reference. CCI edits are posted by CMS to the internet. You don't have to buy them. So those are lists of codes that cannot possibly be coded together. So if NCCI edits are cause for rejection of payment, Medicare does not pay, but neither can the cost be passed on to the patient, as a denial is based on incorrect billing and not lack of coverage. The provider cannot submit an ABN or an advanced beneficiary notice in this particular case. Legislated Medicare exclusions of procedures, the physician can't submit a ABN, which is advanced beneficiary notice, but that means that's before the procedure is done. This all has to happen before the procedure is done if you want to get paid. If you are sloppy and you do the procedure before you have this paperwork secured, you aren't getting paid. That's as simple as it is. So we get the ABN. The ABN is advanced beneficiary notice. Let's say I have an older woman who goes to a dermatology office. This is a really common one. She goes to the dermatology office because she has like a boil and she wants it removed. Well, Medicaid will pay for that. Well, maybe she also goes in there and they convince her that she could look better if she got some liposuction because they do it right next door in the medical spa. That is not a covered service. And in fact, there's laws saying that unless it's a very extensively medically necessary needed, no sort of cosmetic surgery is to be covered. So that's pretty simple and straightforward. They give her an advanced beneficiary notice that says this is not covered by Medicaid or Medicare. This is not a procedure that will be paid for. You will pay for it out of your pocket or you will not get it. Simple as that. A notice of exclusions from Medicare benefits, NEMB, is a form completed and signed by the patient before items, procedures, and services are provided as they do not meet the definition of Medicare benefits or because they are excluded by law specifically. So this happens all the time. You'll get a list in the mail from Medicaid and Medicare saying these services are covered, these are not, okay, with your coverage. But also, the provider can give you a list because they know what's covered and what's not. They bill for it all the time in big provider offices, so they usually know. In a small doctor's practice, you have to find out which ones are going to be covered and which ones aren't. And so you can just call Medicaid and Medicare and ask them. You can even call like a provider like Novitas who can help you. NEMB, which is Medicare Notice of Exclusion for Medicare Benefits, is completed with an ABN, is not appropriate. So here's a list of things that Medicaid and Medicare don't cover, these services. But your service is covered, so we're good. But these ones are excluded by law, okay? And we won't even submit that to them because you will pay. So let's talk a little bit about some problems with encoding. So there's different problems that we encounter. There's upcoding, which means that we try to bump up how much money we capture by incorrectly putting our code together, by picking the one that has the highest payout instead of the one that best fits what happened in the documentation. It's not good, it's fraud. It is illegal and you will get busted eventually. Then there's unbundling. So if you have 4 puzzle pieces and they all fit together and you're able to put them together, that's what you go with. So with the code, that's kind of the way it is. If there are 4 separate pieces to that procedure and they have a separate code for each of them, but then they also have a code that includes all 4 of those procedures, you pick the one code over the 4 codes. Less is more, and it's more accurate. And so when you do the opposite, when you have all of these fit into this, but we want to capture a little more money over here, so we're going to bill for each of these 4 codes. That's called unbundling, and it's like making a picture into a puzzle. And when you make the picture into a puzzle, you're going to get in trouble. And then there's downcoding. You're wondering, why would you ever pick a code that pays out less? Well, I think the only time that would ever happen is in fraud. In fraud, where you're just trying to kind of go under the radar. And so sometimes you hear people downcoding who are committing fraud. So it's not just wrong coding, it's illegal coding, and it's unethical. So upcoding, unbundling, downcoding. Know what they are, don't do them. Know what they are so you don't do them. So let me give you a summary of CPT coding. CPT is for services and procedures provided in home health care, hospice, outpatient, hospital departments, physicians, healthcare facilities, mental health care facilities, optical, physicians in their offices or home clinics, and in the patient's home. It doesn't really matter where the service is provided so much as what the service is and the types, as they fall into these different categories. That is on a CMS 1500 or 1450 form. You will see that you will be able to put a code, a numeric code to where the service was rendered. That's in your CPT code book in the front covers. There are 6 sections in category 1 codes. Okay, E&M, which is evaluation and management, anesthesia, surgery, radiology, pathology, and laboratory, and medicine sections. Each one of them have different coding compliance issues that you'll want to become familiar with, and a lot of them are in the NCCI edits also, so that's a really good resource to have. But a lot of it can be figured out or gleaned from the guidelines or the CCI edits. Then CPT contains category 2 codes for tracking and obtaining performance measures compliant with PQRS. So big hospitals, they write for grants and stuff. They take that government money, they have to track that it's having a benefit, and so they have to know all about these PQRS. Also, if it's a newer technology, there's category 3 codes, and that's to track, let's say we're doing appendectomies with a laser, and let's say that we found that has a better healing rate, people are out of the hospital quicker, it's a new procedure, it's not in HCPCS or CPT, nobody puts it in there, you write for it maybe as a grant to test it, or maybe you've applied for FDA approval for this procedure. You can have a category 3 code, which is a temporary code assigned to that, to track it to see if it's more effective than these other procedures or less effective, and then maybe Medicaid and Medicare services will want to cover that procedure in the future. So then there's also some CPT websites that are helpful. The AMA, CMS, AAFP, Novitas Solutions, HEMA, AHA, and CAHIBA. Okay, they're all very helpful, so save those. Because when you start coding, you won't know what you need until you need it. That's why it's so hard a topic for a lot of people to teach, is that there's so many different areas and not everybody knows everyone, and it really doesn't matter. As long as you're good at reading and you know where the sources are, you can do it. All right, so HCPCS Level 2 coding. So this is my book. It's a HCPCS Level 2 Expert Updatable Optium book. It's from Ingenix, and I like it because it's color coded. It has all the updatable information. I can just add it, and it's in a spiral. HCPCS is pronounced HCPCS. It's introduced in 1983, and it comes from an obsolete coding system originally called the HCFA, for Common Procedure Coding System. The acronym HCFA comes from the time period when Centers for Medicare and Medicaid Services, CMS, was called the Healthcare Financing Administration, and providers used hundreds of different code systems to bill HCFA. So there are two different books that make up HCPCS coding system. HCPCS Level 1, Current Procedural Terminology, CPT. HCPCS Level 2, National Codes. Okay, it's very simple. HCPCS Level 1 is always called CPT. Almost no one ever calls it HCPCS Level 1 anymore. It's an antiquated term. Just call it CPT. Everyone knows what that is. HCPCS Level 2, everyone knows that those are the national codes for durable medical equipment and things of that nature. So HCPCS Level 2 codes, created to describe common medical services and supplies not classified in CPT or HCPCS Level 1. HCPCS Level 2 codes are 5 characters in length, beginning with letters followed by 4 numbers. It covers services performed by physician and non-physician providers, ambulance companies, durable medical equipment, and durable medical equipment, prosthetics, orthotics, and supplies. Maintained by CMS, Medicaid state members, and Medicare Pricing, Data Analysis, and Coding Group, which is PDAC. What up, PDAC? They're pretty cool. Some people will want to eventually work for them, so you might want to get involved with this. There are lots of jobs in this field. There are permanent national codes, miscellaneous codes, temporary codes, and modifiers in HCPCS Level 2. Some of the modifiers are applied to CPT codes from HCPCS Level 2 as well. It's the number one mistake people make when they're doing coding, when they're doing the whole bill. And so they'll forget to put the right modifiers from different books with the right service. So you can see here's at the bottom, here's some examples of HCPCS codes and what they look like. L8690, auditory osteo integrated device, includes all internal and external components, implant, abutment, and sound processor. So it breaks it down. Modifiers in HCPCS Level 2 can be applied to HCPCS Level 1 codes, as I was just saying. Sometimes a HCPCS Level 1 code will need a HCPCS Level 2 code or modifier on the bill to prevent rejection. That's right, sometimes you need the HCPCS code and the CPT code and a modifier from HCPCS. Oh, I guess the baby woke up. Oh. So an example, CPT anesthesia code may need a modifier such as -AA to indicate the services are performed by an actual anesthesiologist or that the procedure was performed on the right side. You might use the modifier RT. The alphabetic first character in HCPCS Level 2 identifies the code section, and then using the alphabetic index is the only way to find the correct code. The HCPCS Level 2 code determines if the claim is sent to the primary MAC that processes provider claims or to the DME MAC that processes DMEPOS dealer claims. I know, lots of acronyms, so let's break that down. The MAC is the Medicare contract administrator, okay, and they process provider claims. And then the DME is durable medical equipment, and then DMEPOS includes durable medical equipment, prosthetics, and orthotics, and other services. So that's what it stands for. Example, when a doctor treats a Medicare patient for a broken leg and gives the patient crutches, 2 claims are generated: a professional services bill for the care of the fracture and is filed with the primary Medicare administrative contractor, the MAC. The second is the claim for the crutches, and it's sent to the DME MAC. The DME is billed either in-house if the doctor is registered as a DME MAC. If not, a prescription for crutches is created and the patient goes to a DME MAC to get the crutches. The DME POS must get a signed certificate of medical necessity, CME, from the treating physician before submitting the claim to Medicare. And so if you work in an office and they don't do this stuff, you are the one who gets to institute it because you're responsible for the billing being as accurate as possible. And so is the physician, so they'll want to listen to you. This is the kind of market that's being created these days because the doctors don't know all of this stuff. They know some of it. So there are different types of injections, and they're all covered as CPT codes for administration of an injection. So this is a good example of this. So there are different types. There's intramuscular, subcutaneous, intravenous, and intradermal injections. And so all of those are CPT codes. Types of drugs used for injection are often a HCPCS level 2 code. And so often there's a table in CPT also with drugs. So check there first. But if it's not there, check in HCPCS because it might have something like the actual medical, what do you call it? The medical table that has the medicinal product that's being used and how it's being administered and all that. And so that's it.